Hello and welcome everyone to another virtual program here at the Macular Degeneration Association. My name is Dustin. I am the Communications Director for the Macular Degeneration Association, and we'd like to welcome you to today's program. We would not be able to bring these programs to you, of course, without the support of our wonderful sponsors, those being Regeneron, Apellis, Sun Pharma, AbbVie, MacuHealth, and No Television. Of course, we also want to thank our board of doctors that help us to steer the organization and help to bring us information that is relevant to you each and every day. Today's is going to be a Ask the Experts panel. So we have wonderful speakers as Dr. Gerson and Dr. Chouse that will be presenting a interactive Q&A with you guys. We just ask that you do not raise your hand and that you do not submit anything in chat, but rather use the Q&A box at the bottom of your screens. So if you have a question, we highly encourage you to go ahead and start putting those in now. We will have a brief presentation by the two doctors, and then they will jump into the questions. So if you want to start getting your questions in now, that is fantastic. Otherwise, we will continue to add them as we go. Our first speaker is Dr. Gerson. He's the medical director for the Macular Degeneration Association. Currently, Dr. Gerson is in private practice, focusing on primary care patients, and has an emphasis on retinal care in his practice. He participates in clinical trials and utilizes many different diagnostic modalities, and is a frequent lecturer in the US and abroad, and writes regularly for optometric publications. We also are being joined by Dr. Paul Chouse. He is an optometrist with a private practice specializing in diabetes eye care and lectures on diabetes, nutrition, and AMD in the US and abroad. He also writes regularly for optometric publications. So, Dr. Chouse, Dr. Gerson, we turn it over to you.
All right. Thank you, Dusty. Appreciate it. Welcome, everyone. Welcome, Paul. Glad you're here with us today.
Thanks for inviting me, Jeff.
Yeah. So, I just want everyone to know I'm really excited to get to do this with my really good friend, Dr. Paul Chouse. When they showed me the introductions, I felt badly because his should be about a page and a half long. I tell people he's probably the smartest person I know when it comes to anything related to diabetes. So you're all in for a real treat. Any questions on that particular topic? He is, I think, really an absolute subject matter expert, along with other things I care. But I'm always excited to get to hear Paul talk about anything diabetes. I always learn. So I'm excited for the questions to start coming in because I probably have some of the same questions that you all do. But Paul and I have prepared just a couple remarks on a couple topics that we thought were kind of timely topics, things that are relatively new and potentially exciting in the world of either macular degeneration or diabetes-related eye disease. And so the first one I'm going to start off with is something that's been of interest to both Dr. Chouse and I for a number of years that we've been following. I'll tell you the name of it. It's a very complicated name, but I'll explain it to you and why it's exciting to both of us. The complicated name is photobiomodulation. And it's actually something you may have heard about in medicine. There's been a bunch of stuff, even in mainstream press, about this. And what photobiomodulation means is using light to change your biology. And so there's a particular instrument that's awaiting FDA approval that, according to the company, they think it will be approved at the end of October, maybe early November. That's a device that would be likely at your eye doctor's office, and it emits lights of a certain wavelength. So you just look into it, and there's lights that shine into your eye. And what those lights do is they change the way that the cells in your retina and your macula function. And they've shown that they can improve vision in people with dry macular degeneration and potentially help prevent the progression of it getting worse. So this is something that's super exciting because normally when we talk about treatments for AMD, we're talking about injections into the eye. And so this is just looking at a light, a very specific light. So it's not just any light. But that's why it's exciting to me, because it's looking at a light and it can potentially be helpful with really no potential negative side effects. So that's something, Paul, that I've been telling my patients to be on the lookout for, and that I'm hoping will be here before the end of the year, and could be something really, really exciting for our patients with dry macular degeneration.
Yeah, I agree. I've been mentioning it to my patients with increasing frequency too. The same technology has been used for people with swelling in the retina due to diabetes as well. So I think there may be multiple applications for this kind of therapy. Might be something you can do. It looks like now the platform is like a few times a week, like a 10-minute session. And so probably we still need to figure out what the optimal treatment level is. How often do you have to go in for how long? But I think it's something really exciting using light energy. It's not a laser. I think that's important. Some patients ask me that. Is it going to laser my eye, damage the eye? No, it's essentially a combination of different light wavelengths or colors of light that can be transmitted through the pupil. In some cases, they're used through the closed eyelid. So basically, you put a little LED on the eyelid, and red light, for instance, is transmitted to the back of the eye, where it changes the biology, the functioning of the cells. It's a cool technology.
Yeah. All right. So what's one of your topics, Paul?
So you mentioned injections. I think it's, maybe the audience already is familiar with this, but what's better, getting an injection in your eye every month or getting an injection, let's say, every 4 or 5 or 6 months? So we now have therapies that last much longer, drugs similar to the ones that we've been using now for decades for treating wet macular degeneration. But these newer agents appear to last a lot longer. So the whole goal is to reduce the treatment burden on both the patient as well as the ophthalmologist typically that's injecting these meds, right? Because a lot of these ophthalmologists that I work with, they're doing 30 plus injections a day. They'd really rather be in the operating room dealing with other cases that require surgery. So anything that can reduce the burden on the healthcare system by requiring fewer injections and get patients good outcomes, equivalent outcomes with fewer injections. Some of these new medications, one of them is a high dose aflibercept. There's another one called faricimab, and both of these, in patients can extend how long between shots, the interval out, 8 weeks, 12 weeks, 16 weeks, even in some cases beyond 20 weeks between injections. Are you seeing patients getting these longer lasting agents in your office, Jeff?
Yeah, I have started seeing some of those patients. And, where this comes up for me, and I think where it can come up for you as, our people logged on today, is if you're getting injections and you're getting injections once every month, it may be just worth asking your retina specialist about, do you think I would be a candidate for one of the longer lasting medications, so that maybe we don't need to do injections quite as frequently. And so I think it's always worth asking. Not everyone's an ideal candidate, maybe even just because of insurance, but I think it's certainly certainly think it's worth asking about. So the next one that I wanted to touch on is something called geographic atrophy. So geographic atrophy is the advanced type of dry macular degeneration. And it is something for which before about 18 months ago, there was no treatment for it. And now there's actually 2 FDA-approved treatments for geographic atrophy. And so I think it's important to realize that if you've been told for maybe years that there was nothing that could be done, it's possible that now there could be a treatment for you. You've probably all seen a commercial for it. So the 2 companies are both doing television commercials. One had hired Henry Winkler, the Fonz, to kind of be their spokesperson and do some public service announcements. And the other one is a company that the commercial shows people painting on their faces with pastel colored paints and painting what looks like strange animals on their face. But what they're actually painting are either turtles, sloths, or I forget the third animal. But what all 3 of those animals have in common is they're very slow moving. And so the idea is to potentially slow down the geographic atrophy from changing. So not to reverse it, but to potentially slow it down so that you have your usable vision for a longer period of time. So I think this is something that's been really a paradigm, complete shift in how things are looked at over the last year and a half. Paul, have you had any patients that you've sent for this treatment?
I have. I've had a handful, and most of them kind of were talked out of doing the treatment by the retina specialist for a variety of reasons. The question is finding, the ideal candidate. We know, though, without treatment, what we call geographic atrophy, because it looks like map shapes in the retina, little areas where the retina has basically atrophied. We know it progresses, and so anything we can do to try to slow it down is going to be a benefit, and these newer agents do slow it down significantly. The other thing I just think is worth mentioning, a lot of people with geographic atrophy, it doesn't start in the center of their macula, in the fovea, we call it. It starts outside the fovea, and it's actually been shown more recently in one paper, and so we have to see if this pans out to be true, that the AREDS formulas actually slow down the progression of geographic atrophy that is outside of the center of vision towards the center of vision. And pretty significantly, it was a little more than 50% reduction in the progression of these areas of atrophy towards the center of somebody's vision. So I think it's kind of, for me, it's been a little bit of a paradigm shift, because we originally, for the last decade or more, have thought that the AREDS formula didn't really help for this severe form of dry AMD. But as it turns out, over about a 3-year period, it slowed down the progression towards the middle of somebody's vision. So I think it's a good idea to keep recommending these supplements to our patients, even when they have dry AMD, not only to prevent conversion, what we call that, to wet AMD, to starting to have bleeding, but also worsening severe dry macular degeneration.
Yeah. Yeah, that is really interesting. I see we're getting some questions coming in, so I might go ahead and jump into some of the questions that you all are sending to us, and just to encourage you to continue sending questions. That's what we're here for. Hopefully we'll be able to answer all your questions. I'm confident we'll be able to come up with something useful. So the first question I'm going to read is there any progress with CRISPR for so basically, is there any progress with CRISPR that's related to macular degeneration? So really, the question here is genetic modifications. Paul, do you want to go first, or do you want me to?
No, I mean, so my knowledge of this is limited. So my cartoon take on it is basically you take a cold virus, you put DNA into the cold virus, you transplant that potentially under the retina. And so, gene modification therapy, essentially what you're doing here is you're creating a little factory in the eye itself that can produce molecules, the same drugs that people with wet AMD are getting injected into their eye on a regular basis. So if you can get a virus to produce the same protein, the same drug, as it were, again, it's another way to extend the treatment interval. So when you're talking about CRISPR therapy, actually modifying the genetics, prior to the onset of the disease, that would be superior to treating it after the fact. And I don't know if there's movement in that regard. Tell me what you know, Jeff.
No, I would have said the same thing. I don't know of anything that's looking at earlier, so before you have macular degeneration to prevent it. But you're right, that would be ideal. Yeah, I find what you're talking about to be very interesting. And what's interesting is it's using a virus to essentially infect cells in your eye in a good way. And so it's going to be a change in the way we think about viruses and infections, or what viruses can do. We need to realize that viruses can carry beneficial properties with them as well. So, but I think it's a really interesting and promising therapy, because instead of getting injections once every month or 2 or 3 months, the companies that are looking at this are looking at treatments that are either a 1 or a 2-time thing and then done. So to your analogy, I love your analogy. It's like creating a factory. It takes 1 or 2 injections to build your factory, then your factory works ideally forever. So I think that's a pretty cool thing. Another question that to go piggyback on what we had just talked about, the new medications that you mentioned for geographic atrophy, will they be able to be used for earlier dry macular degeneration? So I'll take that one. So, as of now, there's been no study looking at using them in earlier macular degeneration. The issue with the injections, just like the injections for wet macular degeneration, is that they're not a one and done. It's that people get an injection and then continue to get injections over time. And so, what would be difficult to justify is knowing that not everybody develops geographic atrophy or wet AMD. Is it worth getting an injection every month to prevent those things that may or may not have happened anyways? So as of right now, that's not what they're used for. It's not what they're approved for or being paid for. That's not to say that there aren't companies looking at potential options for earlier dry macular degeneration. I just don't think that either of the two approved drugs will ultimately be used in that fashion. So someone said, I tuned in a little late. What's the therapy for macular degeneration that I'd mentioned at the beginning of the Zoom? So the photobiomodulation is the general name of the type of therapy. The name of the company is Lumathera. So they're the company that will be coming out with the office-based device. And then the actual name of the device, I have to remember it, Paul. Do you remember?
It's Valeda, I believe.
Correct.
Valeda.
Thank you. So Lumathera and Valeda. So again, not yet approved, but hopefully before the end of the year. That would be, and to be honest, a lot of people, a lot of even eye doctors don't know, haven't talked much about it yet because it's not an approved therapy yet. So that's something that, if you ask your doctor about it, don't be surprised if they need to get back to you, because it is something that's so very new. It's not even out yet.
Light therapy is being used a lot kind of in dermatology settings, right? For clearing up kind of red blotches on the skin and that sort of thing. So they use a very similar therapy to clear up skin conditions. Even medical spas have that available right now. So there may be people that are listening that have already had some sort of photobiomodulation for, let's say, acne rosacea, an adult form of acne that's quite common.
Yeah. Paul, here's one that's right up your alley. It says, I've heard that Alzheimer's is considered type 3 diabetes. Why and what effects can it have on your vision?
Yeah, it's an interesting question. So it's actually a little personal privilege here. My freshman biology teacher in college was the first person to show that the brain itself actually makes insulin. And one of the first things that goes wrong in Alzheimer's disease is the brain loses its ability to produce its own insulin. I mean, I didn't know the brain made any of its own insulin. I thought it all came from the pancreas. But there are cells within the brain that can produce insulin. And so that's why some people have called Alzheimer's disease type 3 diabetes. It's also interesting to note that there's insulin resistance that occurs in a lot of patients with Alzheimer's disease. And so people with diabetes appear to be 2 to 4 times, depending on the study, more likely to develop any sort of dementia, at least doubly likely to get Alzheimer's disease. So there is this link. And does Alzheimer's affect vision? Yeah, in lots of potential ways. What we call visual spatial awareness, your ability to localize, locate objects in your environment, the ability to recognize what they are, to name those objects. So Alzheimer's can affect the eyes. It doesn't directly, damage the eye, but it's more the connections between the eye and the brain. Do you other thoughts about Alzheimer's and vision?
No, but I mean, you're right. It's interesting that Alzheimer's, along with some of the other neurodegenerative conditions, affect the eyes in ways that we can measure. It may not, to your point, may not really affect vision, but it can affect measurements we take that may help give us some insight as to whether someone has or is developing or worsening of some of these neurodegenerative diseases. So, yeah. So another one, I heard there's a new technology coming out that will take photos of your eyes from your home. Can you tell us about this? So probably what this, I think what this may be referring to is a home monitoring technology. So for more than a decade, there's been a technology for monitoring someone's eyes if they have a specific stage of dry macular degeneration, to monitor very closely so that if it changes to the wet kind, it will alert your doctor. The same company that makes that now has a technology that if you're receiving treatments for wet macular degeneration, that it measures in between your injections, it measures changes in the macula or changes in the fluid. And the idea there is that instead of your doctor saying, well, let's try to go 4 weeks, 6 weeks, 8 weeks until your next injection, the idea there is that it will show the doctor exactly when there's fluid accumulating and exactly when your next injection should occur. So it makes it very, very personalized treatment based on your measurements you're taking of your eyes, instead of just kind of hoping or basing on a clinical trial of, of many, many people. All right. Let me go through these again. So someone asked, someone asked, I just saw an article about a new dry eye therapy that will use a drop that will be placed on your forehead. Is this true? Paul, have you heard of that?
I have not, unless it's, there are therapies out there for dry eye that include things like putting an electrode in your nostril, basically stimulating the nerve that makes you cry, produces tears. So maybe it's an onion extract that you put on your forehead, and the vapors from the onion make your eyes water. I have not heard of that.
I have not either. No, the closest thing, similar to what you just mentioned, that I use on a regular basis with patients is actually a nose spray. So there's actually an FDA-approved nose spray that can be used to help people with dry eyes. But I've not heard about anything on your forehead.
No, the nose spray is an interesting. So I know we're supposed to be talking about lots of eye diseases, I guess, but dry eye is probably, if you ask any eye doctor, what's the most common thing you see where there's something wrong with the eye other than needing glasses? It's going to be dry eye. Very, very common. Pretty much my rule is if you are a female after age 65, you've got dry eye until I prove to myself you don't. It's that common in elderly. And 65 not elderly, but it's that common in especially post-menopausal women. And it creates a lot of misery for people. Blurs your vision. It can hurt. Paradoxically, dry eye makes your eyes water because they're so dry. They're producing excess tears to try to compensate for the dryness. So it's a big problem. And that's why companies are spending billions of dollars on coming up with therapies, because it's such a common problem.
Yeah, and there was even a question about that you already kind of alluded to. Someone asked about, my eyes are always watering. How could that actually be dry eye? And to your point, sometimes eyes are so dry that we overcompensate. And the other reason or other thing could be that, with our tears, we need enough, that's quantity, but they need to be the right quality. So if you have poor quality tears, you might keep making more and more and more that aren't doing anything. So you keep making more and they start running down your face. So to your point, Paul, dry can be, quite a nuisance and is really, really quite common. Okay. I've seen that there are many biosimilars coming to the market. Are they the same or different? And will the costs be any different? I'll let you take that one.
Well, so presumably, it's to spur competition, to lower drug costs, right? So I would expect the cost of these medications to be lower than the name branded products. Do they work as well? I mean, that's what biosimilars have to basically demonstrate, I believe, to get FDA clearance, is that they have comparable efficacy, right? The question always is the stuff other than the active drug in the whatever, let's say an injection for wet AMD, they're called adjuvants. Are the other chemicals added in to the mix different than in the name brand product? And is that going to affect, let's say, the comfort of the injection? Are you going to have other potential problems with them? But my understanding is that the biosimilars are exactly that they work the same way with the same safety profile as the original drug.
Yeah. Yeah, there already have been a number of these that have been approved and are being used. So, and theoretically, to your point of competition, theoretically, it really should drive down costs some. I don't think it'll be dramatic, but historically in other areas of medicine, when biosimilars come out, they generally drive down costs somewhere between 25 and 30 or 35%. So, it would be quite a savings, big picture, to the overall healthcare system. By the way, so while Paul was answering that, I tried looking something up because Donna had, Donna, who's the executive director of the Macular Degeneration Association, sent me a text message saying there's a company called Signal 21 that has a phase 3 study going on with some sort of forehead delivery of something for dry eye. So sounded like science fiction to me, but like most things before they become real, they sound like science fiction. So apparently there is something that is apparently a phase 3 clinical trial for dry eye. So thank you, Donna, for pointing that out. Neither of us had heard of that. So maybe you can confirm this. I was recently made aware that preservatives and eye drops, specifically medications for glaucoma, can cause dry eye. That's a really important point. So there's a very common preservative. The initials are BAK, benzalkonium chloride. And historically, it's been a very commonly used preservative that has been known to potentially cause irritation or basically the same symptoms as dry eye. And so it is absolutely true that preservatives can sometimes cause a problem. So the same drops that you're using to help your eyes could potentially be causing a different issue. So luckily, many of the, for example, artificial tear companies now have preservative-free formulations. There are a number of glaucoma medications that are preservative-free, so that if you're using medication on a daily basis, very long term, that you can get medication without any preservatives. So yeah, it's a really important question. Paul, here, let's go to this one. I have basement membrane dystrophy and wet AMD. My eye injections cause corneal abrasions about 75% of the time. Do you have suggestions about that? It occurs with prep or rinsing, not the actual shot.
Yeah, I mean, so basement membrane dystrophy, essentially the outer layer of the cornea, the clear window that's over the colored part of the eye. It has more nerves per square millimeter than any part of the body, if you think about that. A lot of sensitivity. So it hurts when the basement membrane dystrophy occurs in patients. This layer, it's kind of like on your skin, like getting a sunburn. The cells don't stick to the underlying tissue properly. They come off, the nerve endings are exposed, and it hurts. It can create a lot of misery. So it's interesting that it happens each time you get an injection for wet AMD. The first thing I would do is maybe talk to the injecting provider, let them know that this happens each and every time. Can you take maybe greater care to help me with this? But one thing that people with diabetes get this more often. It's not basement membrane dystrophy per se, but it's essentially the same outcome. The cells on the front of the eye don't stick properly. So what's been shown to actually help with this is doxycycline. It's an oral drug that inhibits certain proteins that make the cells on the cornea more likely to get sheared off by any sort of physical pressure, from blinking, from rubbing the eye, from prepping it for an injection per se. So a low dose of doxycycline is a potential. The other thing that I'm interested in particularly is fenofibrate. It's not approved for this purpose. Fenofibrate's a drug to lower your triglycerides. It's taken by mouth, but it's been shown that if you create an eye drop using fenofibrate, it goes by, the brand name is Tricor. Maybe people in the audience are on this particular drug. That the topical version also helped with recurrent corneal erosion syndrome, which is really what happens when you've got basement membrane dystrophy. The cells recurrently, over and over again, erode, get rubbed off the front surface of the eye by any sort of physical manipulation. So I talked to your injecting physician. You might ask about being put on a low dose of a doxycycline medication to help strengthen the connections between the underlying tissue and the cells. The other thing is that basement membrane dystrophy, I've had patients treated with great success by doing a procedure called PTK, where they basically numb the eye, they rub off all the outer cells, laser the tissue underneath. It's like trying to create a clean slate. The cells grow back in, and typically, not always, but typically after this treatment, the cells adhere better. So tell me if I went off the rails on that, Jeff, and if you have other comments.
No, I would say that all sounds appropriate. What's interesting is that if you talk to people about getting injections, usually the actual injection, people will say that it's really not that big of a deal. It's not painful, maybe just a little bit pressure. What generally causes more irritation or problem is it's called betadine, the solution that's used to clean the eye. And so it's usually not the actual injection that is the problem. It's what needs to be done to prevent infection. And so you may even ask that the doctor that's doing the injections, is there something other than betadine you can try to see if I don't have this continue to happen?
Can you think of an alternative? I'm just thinking off the top of my head, what would be, what they don't want to do is introduce a bacteria inside your eye when they're injecting you. That's why they use betadine. You don't want an infection on the inside of the eye because that can be a catastrophe. So, is there another agent?
Yeah, so it's a good question. I don't know if there is, or I don't know if there are different strengths of betadine, if they can dilute it.
Dilute the betadine, right? Yeah.
So there's a question about appropriate dosing for AREDS 2. I've read that too much zinc can cause harm to the cells of the eyes. Boy, that's a tricky one. The first part is easy. The second part is tricky. So I'll take the easy part and I'll give Paul the tricky part. So the easy part is, AREDS 2 is a very large, very well done clinical trial. So there were over 4,000 people in AREDS 2, which is bigger than any trial for any medication that anybody on this call takes. And what it showed was, if you indeed have intermediate dry macular degeneration, how would you know if you have that? You have to ask your eye doctor. You won't know just by the way you see or anything else. You'll have to ask your eye doctor. But the people with that level of macular degeneration benefit from a very specific dosing of vitamins. And so that's why many of you may be familiar with or take an AREDS 2 supplement. The most commonly used one is called PreserVision AREDS 2. The appropriate dosing is 1 pill twice a day. Ideally, you take it with a meal with some fat in it for a little bit better absorption. I tell patients all the time that if you can't do 1 pill twice a day, 2 pills once a day is better than not taking it. So, we can tell you what's ideal, but making sure that you get it, even if it's not under ideal circumstances, is better than nothing. And the reason someone's asking about zinc is this AREDS 2 formula has 80 milligrams of zinc, which is a rather high amount of zinc in a supplement. Paul, do you want to take that part, or do you want me to take that?
No, so my quick take on it is there's some evidence that in some people, maybe 1 out of 6 people in the population, that if you give them too much zinc, there's the potential for it actually making their macular degeneration worse. This has been a highly controversial topic within eye care for the last decade or more. And, it's kind of a battle of dueling statisticians on different studies arguing about what's the case. You can do genetic testing on yourself by swabbing your cheek and see if you have the particular genetic mutations that appear to make you more susceptible to high dose zinc harming your eye. And so I offer every patient that I'm recommending the AREDS supplement to that testing, so we can find out whether or not maybe they're at a higher risk. And then if that's the case, there are no zinc formulas of the AREDS 2 formula, and there are ways to get lower amounts of zinc. For instance, by taking one AREDS formula, that would be 40 milligrams of zinc, and then taking another AMD supplement that has less zinc in it. You're trying to stay under that kind of the threshold, which we believe is around 60 plus milligrams a day, and some people might be bad for their eyes.
Yeah.
So it's a great question. It is complicated. I don't think we have the definitive answer yet. What's your take on the zinc controversy, Jeff?
It's exactly what you just said. And what you just said is that there's not a definitive answer. I think some people feel as though that there may be, but I really don't believe that there's yet a definitive answer on who absolutely should or should not take zinc, or could it affect you? So interestingly, we had 3 questions in a row about dry eye. So I want to touch on those because it's interesting that we get a lot of questions about dry eye, because of what you said, Paul, because of how common it is. That, dry macular degeneration does not cause dry eye or vice versa, but the population that's most at risk for one is the same as the population most at risk for the other. So that's why we see so many people with both. And then the other thing that's really common is diabetes. So it's not uncommon to have a patient that may unfortunately have diabetes, dry eyes, and macular degeneration. So a couple dry eye questions. So I'll just start reading off. So any information about a new eye drop called VEVYE, VEVYE. So it is a new preservative-free formulation of something called cyclosporin, which has long been kind of the standard prescription dry eye treatment that others are compared to. You may have heard of something called Restasis. That is also a cyclosporin formulation, and there's others. Cequa is another. So there's a number of different cyclosporin formulations that are all trying to help your eyes produce more and a better quality of tears. That was one. There was a question about erythromycin for dry eye. And what I would tell you is erythromycin really is not used for dry eye. It's an ointment that is even not very often used, period, much less for dry eye. To be honest, I don't know the last time I prescribed erythromycin ointment. How often do you use that, Paul?
Maybe 26 years ago for a little kid. Erythromycin's a safe antibiotic, so you don't have to worry about side effects as much, but it's not as effective for eye infections. I'm not using it all that often.
Yeah. And so the last one that's actually kind of a big can of worms. It's so talking about different artificial tears. It was a 2-part question. I'm going to go to the part about artificial tears. It says, not long ago, there was a recall on some artificial tears. Does the FDA not control these? What drops should I be using for dry eyes? You want to start that one off?
Well, so apparently there were people who lost their eye from using artificial tears that, this is my, again, cartoon version, were kind of being created in somebody's garage, it sounded like. So they didn't have good quality control, contamination control. And so a couple of these, sorry, there's a lawn guy in front of my house, so hopefully that's not coming from the speaker. But, a couple of the patients, I believe, actually died from infections that extended from the eye into their brain. And so my quick answer to this is use a company that has a lot of value in its stock, right? A big company is less likely to cheat and do something wrong. You use artificial tears that are produced by a reputable company that's the company that is on the the stock market exchange, a big company. They're more likely to have better infection control procedures. That's my thought about that. Don't use stuff that came out of Tim's garage.
Right. Yeah. I mean, to your point, the bigger companies have more lawyers that don't let them get away with stuff. Another great resource for that is ask your eye doctor. Which artificial tear drops would you recommend that I try? For a number of reasons. One, because of what Paul was just talking about, that you want to make sure that it's reputable. But 2, because different tears are different in how they work or interact with your eyes. So your doctor may be able to give you specific guidance for what may be able to work better for you.
Agree. And I wanted to just tag back onto the the attendee's question about glaucoma drops drying the eyes out. And this was kind of in the last few years, a study came out that compared laser treatment for glaucoma against eye drops. And they worked equally well. This was, I forget, 3 years, 5-year study. They were just as good as one another. But the people who had laser therapy, because they didn't need as many drops, they had fewer symptoms of dry eye, reported a higher quality of life. So that's something, if you're taking glaucoma drops, they're irritating your eyes, it's really worth talking to your prescribing doctor about the possibility. Are you a good candidate for a laser procedure? The one that's commonly used is called SLT, selective laser trabeculoplasty. It works better on patients with darker colored eyes and lighter colored eyes, but it is an effective therapy for some patients.
Yeah, absolutely. So here's another question that you and I could go on and on about. I love it that someone's thinking this way. Is the AREDS 2 formula better than a diet high in fruits and vegetables?
Great question.
That's almost like a trick question, isn't it? Yeah. Do you want to go ahead?
No, so I wanted to bring this in at some point in the conversation because it's the Macular Degeneration Association. So the U.S. Department of Agriculture did a study just looking at different diets and major eye diseases, AMD, glaucoma, diabetic retinopathy. And what they showed was that every diet they looked at, there were four. There was a Mediterranean diet, a prudent Oriental diet, which was basically the Mediterranean diet with more yellow vegetables, yellow squash and the like, persimmons, and another one called the Healthy Eating Index diet. Those were all far superior for preventing people from getting macular degeneration than was the standard American high carbohydrate, high fat diet. So to the questioner's point, if we all ate correctly, ate real foods without contamination by pesticides, enough of plant foods, probably that would be just as healthy. I would argue healthier for many patients than taking supplements because they have multiple other benefits as well. Reducing, gastrointestinal cancers, reducing the risk of diabetes, reducing the risk of dementia. Mediterranean type diets have all of these in their favor. More plant foods, healthy oils like olive oil, macadamia nut oil, limited consumption of refined processed carbohydrates, minimal intake of alcohol, which, I like wine, but the American Cancer Society now says they recommend no alcohol consumption because it increases the risk of cancers in your mouth, the highest risk, throat, esophagus, stomach, intestinal tract, probably because the alcohol is at a higher concentration. It gets diluted as it goes through your gut, right? So my solution, when patients ask me about drinking and eye health, what I tell them is, okay, if you want a beer, fine, or a glass of wine, but drink a full glass of water as soon as you're done. Try to flush the alcohol through your system quickly so it doesn't sit on top of your cells and cause mutations that potentially lead to a cancer. Sorry, I went off topic.
No, that's great. So the simple answer is more fruits and vegetables are better. Now to quickly address part of the question though, when you're kind of comparing fruits and vegetables to the AREDS formula, what it's really high in, lutein and zeaxanthin and zinc are three things that it takes a lot of the right kinds of fruits and vegetables to eat to get that much. So, I think that best prevention is certainly lifestyle. So eating healthy, being healthy, other healthy lifestyle habits. But I certainly do see a place for formulations with higher concentrations of certain things in it once a disease forms. But I love the question because most people's diets aren't very healthy. And if they were, they could prevent a lot of problems that they have.
Don't drink fruit juice. Just my little caveat about that, right? Well, one study that just looked at, people that consumed fruit juice every day, 20 times more likely to develop any level of age-related macular degeneration. And we think it's it's the sugar, right? The cells don't like a huge influx of sugar. So you want to try to minimize the amount of sugar in your diet.
Yeah, it's interesting because if someone were to ask us about what's the best diet in relation to macular degeneration, and then ask us what's the best diet in relation to diabetes, the answers would be largely the same. And then if you ask, hey, what are the healthy lifestyle habits for prevention of either one of those two, they're largely the same. It's, try to get some exercise. And what I always tell people is you don't need to run marathons or pump iron, just do something. Either don't become obese or try to lose weight so that you're not obese. Don't smoke. Try to control your blood pressure. And if you do, along with diet. So if you do those things, then those are really the best preventative practices that we know for virtually any eye condition or diabetes, and therefore diabetes related eye conditions. So someone wrote in, I think I have Sjogren's syndrome. I'm being tested for it. I've been diagnosed with dry eye syndrome. Are there special drops for people with dry eyes and Sjogren's? So what I would say to that is there's not a specific drop just for people with Sjogren's. But so people with Sjogren's have generally three things in common: dry eye, dry mouth, and arthritis. And so it is very common that people with Sjogren's will have dry eye that's more than just mild. So what I oftentimes tell people is oftentimes I see people with Sjogren's that their dry eye is very stubborn, that oftentimes just using artificial tears isn't enough, that most oftentimes we then need some sort of prescription medication, whether it's one of the eye drops, a nose spray, or something else we have to do other than just artificial tears. So I would say there's not something specific for Sjogren's, but people with Sjogren's generally need a little bit more attention paid to their dry eye, or a little bit more extensive of a treatment algorithm than just what we might call run-of-the-mill dry eyes.
Yeah, there's an oral drug that I've had a couple patients with Sjogren's syndrome that it's improved the dry mouth and the dry eye considerably. The name escapes me right now. It's available as a generic, but that's something you need to talk to a rheumatologist about.
Yeah. So Paul, what are the prospects for using stem cell technology for replacing damaged photoreceptors?
Wow. I don't know. I mean, what's been tried in the past is like transplanting retina tissue from outside the macula to the macula to see if it could kind of turn itself into normal macular tissue. Those experiments in animals have not been very successful. So can stem cells regrow tissue? Yeah, certainly potentially. And I think what you need is what are called pluripotent stem cells that can kind of differentiate or change into any sort of cell type that you might want to program them to turn into. I don't know a lot about the topic, Jeff. What do you know?
Yeah, so one thing I can add is National Eye Institute started a early phase clinical trial within the last probably 6 to 12 months, looking at doing just what the question is asking. Now, if a phase 1 just started, that means very early stage. And so it's going to take several years for that to show anything. And then after that, it'll be at least a few more years for the next stages of trial. And so what I would tell you is we're probably looking at, I would guesstimate, a minimum of 7 to 10 years before there's anything that is approved. Now, I say that's approved because there have been clinics that have tried stem cell treatments for macular degeneration. But again, it is not an approved treatment, and some have been met with disastrous outcomes. So if someone tells you they're going to inject stem cells for your AMD, I wouldn't let them do it. Is it necessary, if you're going to a retina specialist, is it necessary to see any other eye doctors at the same time or regularly? So Paul, do you have patients that see a retina specialist on a regular basis that you also see?
Yes. All the time, because the retina specialist doesn't really want to deal with dry eye or glaucoma, and they don't really have the time to talk to patients as much as probably they'd like to about prevention, about nutrition and the like. So, and of course, the retina specialist is not going to check your prescription for eyeglasses or contact lenses. So yeah, you really do need to see other eye doctors, but all your eye doctors should work hand in hand with one another. They should be communicating with one another. This is what I'm going to try to help, Mrs. Johnson with. This is, what she's seeing you for, so that we're all on the same page. But, I have multiple patients that see a retina specialist, a glaucoma subspecialist. They see me for their dry eye and to get, updated glasses prescriptions, and because they have diabetes and they want my advice about that. A lot of times by the time people get to the retina specialist, they're dealing with, really advanced stages of disease. So What I like about our profession, optometry, I'll make a plug for us, is that we're really focused in on prevention, on intervening, especially in patients that have a family history, let's say, of macular degeneration. We know it's predominantly a genetic disorder. You can't, right now, at least, change your genetics. So if we can intervene with the 30% that's environmental, good diet, healthy gut microbiome, which is related to everything we've talked about today, including AMD, glaucoma, diabetes, unhealthy gut bacteria are linked to all of these eye diseases and many other diseases as well. If we can talk with our patients about that before they develop, symptoms, that's an ideal situation. So that's my answer.
That's a great answer. Here's a question that this is a brand new one that you and I have never heard. So I don't know if either one of us is going to have a great answer, but we'll give it a try. Any thoughts on the relationship with cystic fibrosis and AMD due to malabsorption of carotenoids necessary for health of the macula when pancreas is not working properly?
Boy, that's a great question.
There's a lot in that one. Boy, I'll take an uneducated stab at it, and then Paul will say something that makes sense. So the very generalized answer that I'll give is that I often tell people that sick eyes oftentimes occur in sick people, and that the same things that are causing systemic illness or sickness are oftentimes at the foundation of eye illness, in particular macular degeneration. So anytime there's poor absorption of, the question here says carotenoids. So that's something like lutein or zeaxanthin that you've probably heard of for macular degeneration. Carrots have carotenoids in it, as it turns out. But any condition where those are not absorbed well anywhere else in the body, they won't be absorbed well in the eye and leave somebody more prone to something like macular degeneration. So it's not difficult to imagine a link between macular degeneration and many, many different systemic conditions. That doesn't mean one causes the other or vice versa, but I think that there may be some of the same foundational issues or defects that potentially could lead to both. I don't know if you have something.
No, I just tried to quickly, do a Google search on my phone. It says, we don't, and this is artificial intelligence, which has now taken over all my searches, says we have no information on a link between cystic fibrosis and age-related macular degeneration. That doesn't mean there isn't a link. It means maybe nobody has studied it yet, or we haven't looked at data that already exists to tease out a relationship. I think it's an extraordinarily good question. We know a lot of patients don't absorb carotenoids well, including lutein and zeaxanthin, after they've had their gallbladder removed. You need bile in your intestinal tract in order to absorb or to help absorb the carotenoid pigments that are good for the eye. And, a lot of people have trouble absorbing lutein and zeaxanthin. We know that lutein and zeaxanthin has a propensity to get stored in your fat cells. So if you're above ideal body weight, the idea here is you may actually need higher doses of lutein and zeaxanthin to get enough into your bloodstream to get carried to the eye to be beneficial for prevention of age-related macular degeneration. So probably higher doses are going to be of some benefit. If you don't have a gallbladder, Jeff mentioned this earlier, when you're taking lutein and zeaxanthin, get some fat consume fat about, at the same time. So kale is every patient I see, I tell them to eat kale unless they can't tolerate it. So I talk to people about heating up kale, which releases the good carotenoids for the eye, putting it in with a little bit of butter or olive oil in the pan in an omelet, which also has some lutein in the egg yolk, as a way to get maximal absorption of what they're eating.
Or another ideal way, Paul, would be to open up a can of sardines with your kale and eat sardines with kale.
Sardines specifically for the fat, the omega-3s, and the fish oil, which is probably good for your brain. Yeah. Jeff and I had a colleague that was really a mentor to both of us. It was one of the original researchers showing that lutein was involved in macular degeneration. He worked at the VA, and he had boxes of sardines in his office. And when he saw veterans with age-related macular degeneration, he handed them a can of sardines and said, this is what I want you to consume every day.
Yeah. So along that topic of consuming different supplements or things that are good for you, do you have any recommendations about additional DHA, taurine, or bilberry? So bilberry was something that I think it was shown by the Royal Air Force in World War II that they thought helped their pilots see better, and so that's where that kind of came from.
At
Although
night, right? Night
at
vision was
night,
better in the
right?
pilots. Yeah.
But that is something that really is neither in our food sources nor in any ocular vitamins, because there really has not been any extensive research to show its benefit. Taurine is something else that can be found in supplements. There was one study that showed, in particular, that showed some benefit to taurine, but again, very few supplements have it in it because it was really just a very limited research that shows any benefit. And then DHA is one of the components of fish oil. And so when people talk about taking fish oil, oftentimes people say, well, I take 1,000 milligrams of fish oil. And I liken that to somebody saying, I eat 1,000 calories a day. Do I have a good diet? Well, I don't know. What are those calories? And so within fish oil, really the healthy parts are what's called EPA and DHA. And that's on the label of any fish oil that you buy. It should say how much EPA and DHA they have. And I would tell people that that's what they should be paying attention to. Fish oils that in general have more EPA and DHA. Now, exactly how much, I don't know that there's a good standard answer for that. Paul, do you have a standard answer for how much EPA and DHA?
I tell people try to get more than 1,000 milligrams of the combination. I don't know if that's the optimal dosage. I've talked to some naturopaths that say, you need more than 2,000. And for lowering cardiovascular risk, there are studies that show you need maybe 4,000, which is a lot.
Which is a lot.
There's always the question about, does it promote bleeding? If somebody's on a blood thinner, is it going to make it worse? And I don't know who to believe, but there's different researchers that have given me different answers on that question. So I think it's something to be aware of. Maybe if you're on a blood thinner, probably talk to your physician. You can do some reading on your own and see if you can tolerate maybe a small potential risk of increased bleeding. But I think 1,000 milligrams is a good baseline of combined EPA plus DHA. So if it's 600 of one, 500 of the other, that's a total of 1,100. That you've passed that threshold. So I think that's reasonable.
That's actually the exact number that I tell people.
1,000.
The thing that I would tell anyone is probably better than taking EPA and DHA is just eating some fatty fish. So just a couple servings of salmon, for example, a week will do as much good as taking a fish oil supplement on a daily basis. So, people might ask, well, is it farmed or is it wild caught? Is it this? Is it that? And, it's probably better if it's wild caught. And there's probably certain species of salmon that are better. But I think any salmon that's not fried is better than no salmon, or even potentially better than a fish oil supplement.
So just quickly on taurine, I feel compelled to say something. So there's animals that are bred to not produce taurine, their retinas die. So you need some taurine in the retina. That doesn't mean taking taurine supplements is going to make a big difference in a human patient. Bilberry, by the way, has been shown in a couple of studies to lower intraocular pressure in glaucoma when it's combined with
Pycnogenol, right?
Pycnogenol, which is French maritime pine bark extract. There is a supplement that Life Extension Foundation sells. I'm not a speaker or a consultant to them, but it's the combination of bilberry and pycnogenol. And they've got a couple of studies that show it lowers intraocular pressure. I've tried it on a whole bunch of patients, and in some people it actually has worked pretty well, and others didn't seem to really have any effect on their eye pressure in glaucoma. So just thought I'd throw that out there.
Here's a really good one, I think, a practical question. Are there good references for molecular markers for AMD or glaucoma? Do online searches like 23andMe do a good job of screening genetic propensity for AMD or glaucoma?
It's a great question.
Very
smart question.
So, 23andMe is kind of like a 30,000-foot view. And it gives a very generalized idea or answer or concept of where you are genetically. But what we know is that if you look at more and very specific markers that you can be a lot more specific. So I almost cringe when people come in and say, well, my 23andMe says I'm going to get macular degeneration. And so first of all, if someone's at higher genetic risk, it doesn't mean you will, it means you're at more risk. But if someone's really interested in genetics of macular degeneration, then I would do one of the 2 commercially available tests that we can order that are specific to just macular degeneration. They don't tell you anything about anything else, just macular degeneration.
Can you say the names of the tests, Jeff, just for the audience so they know
Yeah.
they could ask specifically?
Yes. One is Macular Risk by a company called Arctic DX. And the other company's name is Visible Genomics. And so these are cheek swabs that any doctor can order, pretty easy to order. They both cost, it's going to vary on cost, but somewhere around $200 to $250 to do. And glaucoma, I'm not sure if there's any good genetic tests yet available for glaucoma. Are you aware of any, Paul?
So 15 years ago, there was a company called Occugene, that another cheek swab that they claimed tells you whether or not a patient has what they called aggressive glaucoma, that's more likely to get worse more rapidly. So I have not run that test on anybody.
No.
I monitor my patients, and if patients are going downhill, they're losing their peripheral vision, and that's one of the things glaucoma does more rapidly, then you got to treat that patient more aggressively with eye drops, with laser treatments, with a variety of different surgical procedures for glaucoma.
Yeah.
So I ask my patients, if you've got glaucoma, is there a family history? And did anyone in your family become blind from glaucoma? That, again, is another kind of possible answer that you're looking for to see if somebody might be at a higher risk for having their glaucoma get worse more rapidly. For a lot of patients, it's a slow-moving disease, but not for everybody.
Yeah. Okay. Is it basically guaranteed that if one's macular degeneration is progressing, rather than staying stable at the beginning level, that eventually central vision will be lost, whether or not it turns to the wet form? So basically, I think the question is asking, is it inevitable to lose vision from macular degeneration?
If you live to 120, probably. So our goal, Jeff, I think will agree with this statement. What we try to do is to slow it down so that your eyes function at least as long as the rest of you does, so that you depart this world with usable vision. So we can definitely slow it down. I wouldn't say it's inevitable. And a lot of people with severe vision loss from macular degeneration, they resent being called blind because most of them don't say, I'm blind. Eye doctors define blindness differently from the way that the rest of the population does, right? It's a very specific definition. But what most patients think about when you say blind is black, right? Nothing, no vision. And people with AMD typically retain good peripheral vision, are able to navigate about the room, and can function quite well, even when there's severe loss of macular cells.
Yeah, true.
What's your answer to the person's question, Jeff? Is it inevitable? It keeps getting worse?
No, I think it is not inevitable. And I think, I love that the Macular Degeneration's website is macularhope.org, because I think that portrays positivity. And so I have many patients that I've followed for many years with macular degeneration that still have really good vision. So I was actually filling out a form today. Some of you may have heard of something called 4C Home. It's a digital system to monitor your vision at home if you have a certain level of macular degeneration. And I think Paul and I both prescribe it to patients as needed. And I was filling out a form for them for my patients that are using this home monitoring system, that you have to have what's called intermediate macular degeneration, so more than mild. And I was filling out a form for what's their visual acuity. So what's their vision? And I did it today I filled out a form for about 30 patients. And I think 27 of them were 20/20. So that's 27 out of 30 people that has fairly advanced dry macular degeneration, and they're still seeing 20/20. So I think there's absolutely reason to believe that you can maintain good vision. There was a question about a while back, there was an implant that would store the medication for wet AMD for 6 months. What happened to it? I haven't heard much about it. You want to take that one?
Susvimo, is it still called that? Yeah,
Yeah, I believe so.
it's an implant that they can put in the eye, fill it with the medication that's used to treat wet AMD or diabetic macular edema, for that matter, and it has really good efficacy. It was taken off the market because there was a problem with contamination, I believe, of the port. There was a problem that they had to work out and get reapproval from the FDA, and that's occurred now. So that device, it's like a little port for somebody that's getting chemotherapy, let's say for cancer treatment. It's in the eye, sits there. You fill it up with the medication, and it kind of slowly, has a little plunger, I think, that slowly drives the medicine into the eye over a period of time. And people can get like 6 months between refills.
Yeah, about 98% of people can go 6 months. So it's really has the potential to really change the way people are treated. So again, another thing that's worth asking if you're getting injections, another thing that's worth asking if you may be a good candidate for that.
And it's port delivery system, right? Is that the name they should ask about? Yeah. PDS.
Yep. You're exactly right. Port delivery system. Are there ways to preserve or repair the rods for night vision? What causes them to be damaged in the first place? So, interestingly, the first thing that oftentimes goes in macular degeneration is that people become, they're not able to see as well when it's dark. And that's because of loss of what's called rods. So we have cones and rods. And we generally think of the cones being much more highly concentrated in the macula, where we develop macular degeneration, but there are also rods. And so oftentimes the rods are the first to die off. And they die off as a natural part of the macular degeneration process. Is there a way to preserve or repair the rods? Not that I know of, that there's not yet a way to either preserve, well, for sure not to repair. I guess preserve would be the same question as if someone has early AMD or wants to prevent AMD, what are healthy things that you can do to try to prevent its development or progression? And it's really the things we'd already talked about as far as vitamins, diet, exercise, weight loss. The other one I didn't mention earlier is smoking. That, any of these preventative measures that you take are potentially a big step forward. But if you smoke, that's like 2 gigantic steps backwards. So it's not to say don't do the other things, but smoking has tremendously negative effects. And we do realize, however, that it's much easier said than done to just say, well, you ought to quit smoking. It's very, very difficult, and we know that. But it's important that people know that smoking can have potentially grave effects.
The other thing I would throw into the mix, Jeff, is sleep. So if you want to preserve your rods, don't sleep more than 9 hours a night. When your eyes are closed, your rods are metabolically active. They consume more oxygen from your blood supply. And there is evidence, in fact, that people that sleep too short, less than 5 hours a night, or more than 9 hours a night are more likely to get macular degeneration. And what is preserved by sleeping, the sweet spot is about 7.5 hours a night. If you sleep 9 hours a night, the rods suffer. And if they're already under stress from a disease like macular degeneration, it might make that worse. In Europe now, they're using light-emitting diodes that you wear on your eyelids at night to keep the rods at rest, basically to keep them asleep while you're sleeping, so they're not sucking up all the oxygen that the blood stream is delivering to the eye.
Yes,
and sleep apnea, we didn't talk about it, but it's also been shown that people with untreated sleep apnea don't respond as well to the medications they inject into your eye for diabetes or macular degeneration. So simply wearing a CPAP, if you need one, can really help your retina specialist take care of your eyes.
So someone sent in kind of a personal question for themselves. A cornea specialist is talking about having my blood taken out and sent to a company that does something to it, and it's given back to me. I can't remember in what form. They said insurance won't cover. So if someone explained something like that to me, I'd say that sounds kind of weird. But what it is, it's basically you go to a lab, you have your blood drawn, and then they take certain parts of your blood to mix with essentially tears, artificial tears, to make an eye drop out of it, so that you're using the healthy proteins and other healthy components of your blood to help heal your eyes and dry eye. So it's never a first treatment that's done. It's never kind of, hey, let's try this first. But oftentimes, so someone asked earlier about Sjogren's. Sometimes that's something that we need to resort to in people with Sjogren's syndrome. So it's a very different kind of way to obtain your eye drops, but it's more common than someone would think from the way that it sounds.
Yeah, I got 5 patients. It's called autologous serum. They're taking your serum, turning it into an eye drop, has all the healing properties of your natural blood is the idea, so the eye can heal better in severe dry eye. It is expensive.
Yeah.
Very expensive.
So, Paul, we're getting to the end of our time. I want to end with a question that I want to give to you, because I want to learn from you. It says there has been new information about diabetic eye disease. Are there new treatments that are coming out? So if you had to talk about, 1 or 2 new treatments for either diabetic eye disease or diabetes in general that you would be excited about, I'd love to hear about that.
Well, so it's the same agents we talked about earlier that extend, how long you can go between injections for diabetic retinopathy or macular edema. These new drugs that last longer. So that I think is a big breakthrough in terms of, preventing diabetic retinopathy. The best solution is to not only have good blood glucose control, but to see your eye doctor regularly, so that if anything does go wrong, it's caught early so that you can intervene earlier. And this is counter to what I was told. I've had diabetes 56 years. I got it as a little kid, almost went blind in college from diabetic retinopathy. And one of the things that's becoming clearer is that if you have a lot of hypoglycemia, that damages the retina. So low blood sugar, not just high blood sugar, damages the retina. Multiple different studies show this. So I'm a huge fan of wearing one of the continuous glucose monitoring devices. You can get one on your own without a prescription now. Dexcom now has a device, forget what they're calling it, but it's been on TV ad nauseum the last week. So you can actually put this little thing, has a little wire that measures your blood glucose constantly, and you can kind of see how your diet, your activity levels affect your blood sugar. And what you want to do is to try to minimize low blood sugar and high blood sugar both. They're both harmful for your eyes and your brain. Eye is brain. So a lot of people with eye disease have ultimately end up with cognitive issues as well over time, because the retina is really an extension of brain tissue. So everything you do that's good for your eyes is also good for your brain and your cognitive functioning.
Yeah, it's all related, isn't it?
Do you have any other new stuff? It's such a broad question. I just read today that Mounjaro, which is a great weight loss drug, put me in the ER. I lost 30 pounds, but I ended up in the ER. Has been approved in a vial. And so it cut the cost in half. So Mounjaro is a weekly injectable. Now they have a vial, like you're drawing insulin out of a vial. And so the cost went from about $1,100 a month to $550 a month. And the drug really is wonderful for weight loss. It's already been shown this last week to cut mortality, death risk by about 20%, probably by helping people with excess weight lose that weight. And I would bet, but I have no definitive evidence, that these drugs will also help lower the risk in some patients of developing macular degeneration.
Yeah. So by the way, Paul, the product from Dexcom is called the Stelo.
Yeah, Stelo. Stelo. 1L. Yeah.
Yep. 1L, and it's $89 per month. So each sensor lasts about 15 days, and it's $89 for 2 sensors. So if anyone was wondering. All right. So we've hit about an hour and 20 minutes, and we've gotten through, I think, all or almost all the questions that were asked. I want to thank everyone for tuning in. I especially want to thank my really good friend, Paul Chouse, Dr. Chouse, for joining and really adding a lot to this conversation. If you have anyone, if anyone that's on has not been to the MDA, the Macular Degeneration Association website, it is Macular Hope, Macular, MACULAR, Hope, HOPE.org. And it is just a wealth of information, knowledge. It's a great place to really to go and learn. A lot of great information there. Macular Degeneration Association also sends out quarterly newsletters. I think Dr. Chouse had an article in the last one. So again, another great way to just learn about macular degeneration and quite frankly, other eye conditions as well. The last thing that I'll tell everyone is that Macular Degeneration Association is a nonprofit organization that if you go to the website, you can find ways to help support the organization to be able to continue to put on programs like this or the in-person programs that we do. So depending on where you live, you may be able to see one of us or another provider do an in-person seminar answering many of the same questions like we did today. So, Paul, any other final words?
No, Jeff, I want to thank you. I want to thank MDA for inviting me and thank the sponsors of the program. We couldn't do this without their support.
Absolutely. All right. Thank you very much. And hopefully we'll see you on the next webinar.